Hello everyone, now we will be starting the new chapter of renal stones. Okay, from renal stones you can expect that you will be getting a short note. So renal stones are basically due to the formation of crystallines. Okay, because like if I draw a urinary bladder, you have your ureters over here, and if somehow there will be a stone, there will be an obstruction. I have given you the example of if there are vehicles coming from a four-way highway and they merge to a one-way only, there will be obstruction, right? So similarly, if the stone gets stuck, there will be obstruction. They most commonly arises in the kidney but can occur anywhere in the urinary tract. What is the epidemiology? Common in adults, peak at the age of 30 to 50 years. More common in males than females. High recurrence rate is there, and you have something called as the snow belt areas, like in the hot climates like North India and Middle East Asia. What is the pathogenesis? First, there is stone formation. Mainly depends on the promoters that are there, like the salts. What are the salts? You have the calcium oxalate, then you have the phosphate, uric acid, and cystine. Okay, they leads to the nucleation. Nucleation of what? Nucleation of small crystals. And then there is crystal, like the small crystals will be there. After that they form a stone. Okay, after that they form a stone. So what are the risk factors that promote the stone formation? That is nothing but your magnesium citrate and 𝗵𝗵𝗃 proteins. What are the risk factors? You have the metabolic, like if the person is having increased level of calcium, that is the absorption of the calcium is not proper. If there is renal leakage, if there is reabsorption, okay, if there is hyperglycemia, like the condition of gout, if the patient is having gout. What are the anatomical causes? If there is any obstruction in the pelvic urethric junctions, right? These are your ureters. If there is any obstruction, if there are any infections like the urease producing bacteria, like your protease can be there. Then you have the dietary. If the person is not taking the proper amount of diet and is not consuming the right amount of meat, then he or she can develop stones as well. What are the types of stones? First one you have is the calcium stones. You have the calcium oxalate and calcium phosphate. They causes the hypercalciuria. There will be increased level of calcium. There will be 𝗵𝗵𝗃. In the X-ray, you will be able to appreciate that the stones will appear the radio opaque. Then you have Struvite stones. They are associated with UTI. If in the case they will give you that the patient is suffering from UTI, you have the first stone that should come to your mind is Struvite stone. Okay. Then next you have is the Uric stone. Uric name is only suggesting that is due to the hyperuricemia, right? Like the condition of gout and chemotherapy, if the patient is on chemotherapy. Most common in acidic urine. Next you have is the cystine stone, that is seen in your cystinuria. It is hexagonal. It is, just give me a second, hexagonal. Not your benzene ring, it is hexagonal in structure. What are the clinical features? The first one will be renal colic. There will be a lot of pain that the patient will tell you that doctor, I am suffering from a lot of pain. There will be severe flank pain will be there that radiates to the groin, testis or labia, right? Hematuria. There will be blood in the urine that will come out, okay? Because the urine is not getting enough amount of space to pass, right? So the stones will damage. Whenever the stones are like, if I draw, these are your stones. If they are passing, they are not getting enough space, right? They are not getting enough space, as a result of which what will happen? They will try to create a space for themselves by damaging the walls, right? There will be urinary symptoms like there will be increased in the urine, there will be dysuria and urgency of the urine. Infection signs can be, there will be fever and there will be chills. What are the complications you can have? In the complications, there will be obstructive uropathy, which will lead to the hydronephrosis. There will be recurrent UTI. Okay. Then there will be CKD and pyonephrosis. What are the investigations you will order? First thing first, you have to order the urine examination. In urine examination, in the microscopy, you will be able to see the crystal. If the crystals are hexagonal, diagnose that it is a case of cystine. Okay, cystine stones are there. If the crystals are needle shaped, it is uric acid. See, uric acid is having I means needle. If it is envelope shaped, diagnose it as calcium oxalate. For the urine culture, if infection is suspected, then you have to do the urine culture as well. You have to do the 24 hours urine analysis for the calcium oxalate stone and for the citrate and uric acid stones. Blood test, you have to check the serum calcium level, phosphate level, uric acid level and PTH. So these are basically the routine investigations that you have to do. Right. What are the imagings? You have the X-ray of KUB. What is KUB? KUB is kidney, ureter and bladder. Both the X-rays you have to do. They detect the radio-opaque stones like your calcium struvite and the cystine partially. Okay. In the USG, it is good for hydronephrosis and radiolucent stones. For NCCT KUB, it is gold standard and it detects all the stones, even the radiolucent stones as well. What is the management? Before the management, you also have the intravenous urogram. It is rarely done, but it is done. You will read that in your surgery lectures in more details. Okay. Now, what are the management part? For the management, you have the conservative management and medical management. In the conservative management, you have to give hydration to the person. You have to ask the person that at least 2 to 3 liters of water per day. Then you have to give the analgesia like the NSAIDs. Then you have to give the medical expulsion therapy, alpha blockers, calcium channel blockers. Second thing that you have to give is your special medical therapy that depends on the types of stone that we are dealing with. If it is calcium stone, you have to give the thiazide diuretics and potassium citrate. If it is uric acid stone, you have to give allopurinol and alkaline urine and alkalized urine. In the cystine stone, give the high fluids, alkalizations and the tiotronin. In the Struvite stone, give the complete stone removal and plus or minus treat the UTI if the person is having the urinary tract infections. Then you have the very important the surgical options that are there with you. You have something called as the extracorporeal shock wave lithotripsy. What happens is it is best if the stone is less than 2 centimeter. ESWL is best. Okay. What happens is we give the electron, we give basically the shock, and with that, not the shock, we have something called as a motion, a continuous to and fro motion is there that we give, and they basically helps in destroying the stone. Okay. Then you have something called as the ureteroscope with laser lithotripsy. For ureteric stone, you have also can have the PCNL. What is PCNL? That is percutaneous nephrolithotripsy. If the stones are larger than 2 centimeter, then we do the PCNL. Then we have the open surgery. It is rarely done, right? So what are the things we have read in the renal stones? In the renal stones, just remember how the renal stones are formed. Like if there will be a stone in between the PUJ, that is the pelvic urethric junctions, there will be obstruction, as a result of which there will be a lot amount of hematuria that the person will have. Then we have also seen the types of stones, right? What are the types of stones you have seen? We have seen there is calcium stone, calcium oxalate stone. We have seen there is Struvite stones. We have seen there is uric acid stone. We have seen there is cystine stone. Clinical features, we have seen that there will be a lot of pain that the patient will complain of, right? We have also seen the complications, investigations and surgeries that we can do. I think we are done with this chapter. If you are having any sort of doubt, please feel free to reach me. Please feel free to DM me. Thank you so much.